What if the biggest threats to human health weren't always visible? What if they often came from the smallest creatures all around us? Welcome to the Deep Dive. Today, we're plunging into a really crucial area of public health and biology, zoonotic viruses. Our mission, as always, is to extract the most important nuggets of knowledge from some pretty comprehensive medical texts, giving you a shortcut to being genuinely well-informed. We'll explore how these microscopic invaders operate, what kinds of diseases they cause, and how they impact human populations, all with, I hope, some surprising facts and maybe a few aha moments for you along the way. Okay, let's unpack this. We're talking about zoonotic viruses. What exactly makes a virus zoonotic? What does that mean?
Right. So in a nutshell, zoonotic viruses are basically those that naturally circulate among animals. That's their home base, so to speak. Sometimes humans just sort of get infected by accident. That's not part of the plan. Other times, these viruses are, regularly introduced into human populations by tiny carriers. We call them vectors, things like arthropods.
Oh, insects and ticks.
Exactly. Insects and ticks. Or sometimes it's through contact with rodents that are chronically infected. What's truly fascinating here is just how incredibly diverse these viruses are. Not just in, how they look or replicate, but their survival strategies. They're really different. And they're constantly evolving. I mean, we're discovering new ones, quote unquote, all the time.
That makes a lot of sense.
Yeah.
And I imagine environmental factors, things like weather patterns, must play a huge role in their spread.
Oh, absolutely. Huge. Changes in our environment, think rainfall, temperature shifts, they profoundly affect these vectors, the animal reservoirs, wildlife, livestock, and ultimately us. This leads to changes in where you find these viruses, their geography, and also when they're most active, their seasonality. And while, many are prevalent in the tropics, which people expect, we also find them in temperate zones, even in frigid climates sometimes. That can be quite surprising.
So if we dive into those maintenance strategies you mentioned, let's start with the arthropod-borne ones, the arboviruses.
Yeah.
How do they typically make their way to humans?
Okay, arboviruses. They essentially, they hitch a ride. They infect their arthropod vectors, often mosquitoes, right? When the mosquito takes a blood meal from a viremic vertebrate, basically, an animal with the virus actively circulating in its blood, usually not a human. The virus then has to incubate inside the arthropod. It needs to get from the gut to the salivary glands. We call this extrinsic incubation. In mosquitoes, it typically takes maybe 1 to 3 weeks. And another important point for their survival is something called transovarial transmission.
Transovarial, what's that?
It means the virus can pass directly from a mother arthropod, like a mosquito or tick, straight into her eggs. So the offspring are born infected. It helps keep the cycle going even without needing an infected animal host right away. Now, the arthropod itself, usually unharmed by the infection, and the natural vertebrate partner, the animal host, typically has only a transient viremia virus in the blood for a short time with no overt disease. They don't really get sick.
Right, so the mosquitoes and the animals are mostly okay.
Pretty much. Humans in this cycle were typically accidental hosts.
Meaning we're not really part of their normal plan.
Exactly. We're not needed for the virus to keep going in nature. We usually get infected through an arthropod bite, kind of stumbling into their cycle.
I remember reading something, maybe in the source materials, about some of these having unusual transmission routes, like not just bites. Is that right?
That's spot on. Yeah, under specific circumstances, some flaviviruses, that's a type of arbovirus, includes things like Zika, dengue, West Nile. They can actually be transmitted by aerosol.
Breathing them in?
Potentially,
Yep.
or even through contaminated food products. The specific example given is raw, unpasteurized milk transmitting tick-borne encephalitis virus.
Wow. So drinking raw milk in certain areas could be a risk for that specific virus.
It could, yeah. It's a key insight, especially for people who consume unpasteurized dairy in regions where TBEV exists.
Okay, and then we have the rodent-borne viruses, the roboviruses. How do they keep going, and how do they typically jump to humans?
Roboviruses, yeah, they have a different strategy. They're maintained in nature mainly through transmission among rodents. These rodents are chronically infected.
Meaning they have it for a long time.
For life, often, but they rarely show overt disease. They seem fine. And what's really fascinating is their specificity. There's often a high degree of rodent virus specificity. Like, each mammoranovirus that's one group is usually highly adapted to one particular type or species of rodent.
So one virus, one specific mouse or rat type.
Pretty much. Humans usually get infected by inhaling or having direct contact with infected rodent excreta droppings, basically, or secreta, like urine. Think about aerosols from harvesting machines kicking up dust that contains dried rodent waste.
Duh.
Yeah, or dried urine or feces in barns, sheds, even houses sometimes, or direct contact if you're, say, handling rodents caught in traps.
So unlike arboviruses, where it's usually a bite, with roboviruses, it's more about that environmental exposure to rodent waste, right? Does that mean person-to-person spread is rare for these?
Generally, yes. For most roboviruses, person-to-person transmission is uncommon. The notable exception, the one that really stands out, is Andes virus. It's a type of hantavirus found in South America.
And what's different about Andes virus?
It's quite unusual because it can and has been documented to transmit directly between people through close personal contact. That's not the norm for hantaviruses.
Okay, that's a really important distinction. Now, given how incredibly diverse these viruses are, you mentioned different strategies. Can you maybe give us a quick flyover of some of the major groups or families we might encounter? Just the highlights, what makes them unique, without getting totally lost in the details.
Sure, happy to. Think of it like different branches on the virus family tree, each with some key features. So first, Flaviviridae. This family includes some big names you've likely heard of: yellow fever, dengue, Zika, West Nile, tick-borne encephalitis. They typically have single-stranded RNA, positive sense, they're spherical, and they have an envelope, a fatty outer layer, mostly spread by mosquitoes and ticks.
Okay, Flaviviridae, got it.
Then there's Orthomyxoviridae. We usually think of influenza viruses here, but there are some arthropod-borne ones too that are medically relevant, like corongavirus and the gotovirus. Different structure, segmented genome.
Right.
The order Bunyaviridae is a really big, diverse group. It contains several important families like Arenoviridae, that includes Lassa virus and the South American hemorrhagic fever viruses, Hantaviridae, causing HPS and HFRS, Neroviridae, like Crimean Congo hemorrhagic fever virus, Parabunyaviridae, like lacrosse virus, and Finuiviridae, like Rift Valley fever virus and sandfly fever viruses.
Yeah.
These are often spherical or sort of variable-shaped, pleomorphic, also enveloped. A key thing is they usually have a genome split into 3 segments of RNA, and how they're contained varies. Hantavirids, the rodents, shed virions chronically. Nerovirids are usually transmitted by heart ticks, ixodid ticks. Parabunyavirids, mostly mosquito-borne. Finuivirids often show vertical transmission in arthropods, parent to offspring.
Okay, that's a lot under Bunyaviridae, the first group.
It really is. Then Togaviridae, another family. This includes the alpha viruses like chikungunya, Ross River, eastern equine encephalitis. These also have positive stranded RNA, enveloped virions, sort of icosahedral shape, and they're transmitted mainly by mosquitoes.
Chikungunya, right.
Yeah.
Known for that joint pain.
Exactly. Then Rhabdoviridae. Think rabies virus, but there are arthropod-borne ones too, like vesiculovirus. These are distinctive, often bullet-shaped, though sometimes more variable, enveloped negative sense RNA.
Bullet-shaped, interesting.
And finally, Rioviridae. This group includes cultivirus, like Colorado tick fever virus, and orbovirus. What's really unique here is they are not enveloped.
Not enveloped, so that outer fatty layer is missing.
Correct, which makes them generally tougher, less susceptible to inactivation by detergents, for instance. They have a multi-segmented genome, but it's double-stranded RNA, unlike the others we mentioned. Cultiviruses are tick-transmitted, orboviruses by mosquitoes or ticks.
Okay, that's a great overview. It really highlights the diversity. Now, switching gears. For us, the potential patients, what does all this mean when someone actually gets sick? How do these hidden threats get tracked down? It sounds complicated.
Well, the first big clue often comes from geography. A patient's origin or recent travel history is absolutely crucial for diagnosis. Why? Because these viruses and their vectors and animal hosts are usually restricted to specific areas. Knowing where someone might have been exposed really narrows down the possibilities.
So it's not just any fever. It could be anything, anywhere. Location matters a lot.
Exactly. And what's perhaps surprising, maybe a key insight for you, is that these diseases aren't just found out in the wilderness, remote rural areas. Many, like yellow fever, dengue, even Sol virus, which is carried by urban rats, can easily be acquired in dense urban settings too.
Okay, so geography is key. But how do doctors actually figure out what's causing the illness when someone shows up with symptoms? It must be a real detective challenge.
It definitely can be. Some clues from the patient's history help. While, interestingly, a history of mosquito bites doesn't usually help much diagnostically. They're just too common.
Right, everyone gets bitten by mosquitoes.
Exactly. But a history of tick bites is much more useful, more specific. And crucially, Any known exposure to rodents or environments where rodents live is a really key clue if we're suspecting Mammarinoviruses or orthohantaviruses. For the lab diagnosis during the acute phase when someone is actively sick, we try to find direct evidence of the virus. Doctors will often take blood samples, acute phase serum, to try and isolate the virus itself, grow it in culture.
Is that easy to do?
Not always, and it can take time. Another standard method is using paired serum samples. You take one sample early in the illness and another one later, maybe a couple of weeks later.
And what are you looking for there?
You're looking for a rise in antibody titers. Seeing the antibody levels go up significantly between the two samples confirms a recent active infection. For the really serious stuff, like viral hemorrhagic fevers, there's been a lot of work to develop rapid tests. Things like antigen detection ELISAs, IgM capture ELISAs, and multiplex PCR assays.
PCR, that's the genetic test.
Right. These can sometimes give a diagnosis within hours, which is absolutely vital when you're dealing with potentially deadly, fast-moving diseases.
And what about more advanced genetic testing, or looking specifically at the immune response?
Yeah, so more sensitive molecular tests like RT-PCR, reverse transcription PCR, are really powerful. They can detect even tiny amounts of the virus's genetic material, its RNA. Plus, RT-PCR can give us genetic information about the specific strain of the virus, which can be important for tracking outbreaks. For some infections, like those caused by orthohantaviruses, the ones causing HPS and HFRS, the diagnosis often relies heavily on detecting specific antibodies the body makes early on, called IgM.
Why IgM specifically for those?
Because the illness in hantavirus infections is largely immunopathologic, it's driven more by the body's own intense immune response to the virus rather than direct damage by the virus itself. So seeing that early IgM antibody response is a key diagnostic sign. And for brain infections, the encephalitis diagnosis can be tricky. By the time someone has clear neurological symptoms, the virus might not be detectable in the blood anymore or only at very low levels.
So how do you diagnose it then?
In those cases, finding IgM antibodies or detecting the viral RNA using RT-PCR in both the blood serum and the cerebrospinal fluid, the fluid around the brain and spinal cord, which you get via a spinal tap, is highly valuable.
What about imaging, like CT or MRI scans of the brain? Are they helpful in diagnosing these viral infections?
That's a good question. Generally, CT and MRI scans are considered nonspecific for these particular viral infections.
Meaning they don't show a unique pattern that screams, aha, it's West Nile or something.
Exactly. They don't usually have a signature look for these viruses. However, they are absolutely crucial. You need them to rule out other potential causes of the symptoms, things that might require different urgent treatment, like a stroke, a brain tumor, or a bacterial abscess.
So they help rule things out.
Precisely. It's also important for you to know that these scans might look perfectly normal early in the disease course, but then later on, as the illness progresses, abnormalities might start to show up. So a negative early scan doesn't completely rule out these infections.
Okay, this is where it gets really interesting for me. How do these microscopic invaders actually make us sick? I understand the human response can vary a lot, right?
It really does. Hugely variable. While everyone's body reacts differently and symptoms can overlap, we can broadly group the human responses into 5 main categories, or syndromes as they're called. These are first, arthritis and rash; second, encephalitis or brain inflammation; third, a more general fever and myalgia, which is muscle pain; fourth, pulmonary or lung disease; and fifth, the really severe one, viral hemorrhagic fever, VHF.
5 broad categories.
Yeah. But a really crucial insight here, something to definitely remember, is that the most severe forms of these diseases, like the encephalitis or the hemorrhagic fever, are not always the most common way the infection presents.
Oh, interesting. So you can get infected with West Nile virus, for example, but not necessarily get the severe brain infection.
Exactly. West Nile, or say Venezuelan equine encephalitis virus, they very often cause much milder flu-like syndromes, just fever and aches. The severe encephalitis is actually the less common outcome, even though it's the one we hear most about because it's so serious.
That's a really important perspective. Okay, let's start with that first category, arthritis and rash, or AR. Which viruses are the main culprits here, and what makes their symptoms stand out?
The key players in the arthritis and rash category are mostly arthropod-borne alphaviruses, part of that Togaviridae family we mentioned. Think chikungunya virus, Ross River virus, Barma forest virus, and also one flavivirus is important here, Zika virus. Let's talk about chikungunya first. It's endemic, meaning constantly present in parts of rural Africa, and it causes these intermittent, sometimes huge urban epidemics across Africa and Asia. It really gained global notoriety from that massive epidemic in the Indian Ocean region starting around 2004. It spread like wildfire, largely fueled by travelers. And importantly, the Asian tiger mosquito, Aedes albopictus, which is a very aggressive daytime biter and lives close to people, became a major vector.
And that mosquito's found in other places too, right? Like the U.S.
It is, yes, which is why outbreaks in the Caribbean more recently, around 2013, 2014, led to imported cases and even some local transmission appearing in places like Italy, France, and the U.S. It definitely poses a threat to the southern U.S. where that mosquito is established.
And the symptoms. What's the really telltale sign of chikungunya? People talk about the pain.
They do. The striking feature, the hallmark of chikungunya, is the severe, often debilitating migratory joint pain. It's called polyarthralgia.
Migratory, meaning it moves around.
Yeah, it often jumps from joint to joint. Typically affects the smaller joints, ankles, feet, hands, wrists, but larger joints like knees and shoulders can also be involved. It can be incredibly painful. Patients usually have a very abrupt onset after a 2 to 10 day incubation period. High fever, often in a saddleback pattern where it goes down then comes back up, chills, headache, just feeling generally awful. A rash often appears around the time the fever starts to break.
And does it go away quickly?
That's the kicker. Recovery can take weeks. And what's a truly surprising and critical point about chikungunya is that a significant portion of middle-aged to older patients develop chronic disabling arthritis or arthralgia that can persist for months, sometimes even years after the initial infection is gone.
Years. Wow, that makes it a much bigger public health issue than just a short-term fever.
Absolutely. It can have long-term impacts on quality of life and ability to work.
Are there other ways chikungunya can be transmitted besides mosquito bites?
Yes. It's known that it can be passed from mother to baby during birth, maternal-fetal transmission. And quite surprisingly, perhaps, sexual transmission has been documented. The virus can persist in the testes for a considerable time, up to 160 days in some reports.
160 days, that's a long time.
It is. And blood product transmission is also a concern. Unfortunately, as of now, there are no specific antiviral treatments or licensed vaccines available, so treatment is supportive rest, fluids, pain management, often with NSAIDs.
Okay. What about Ross River and Burma forest diseases? You mentioned them too. How are they similar to chikungunya?
Clinically, they're very similar, often indistinguishable from each other, and sometimes even from mild chikungunya. In the past, they were often just lumped together as epidemic polyarthritis because that joint pain is so prominent. Ross River virus causes epidemics mainly in Australia, Papua New Guinea, and some South Pacific islands. Its main vectors are Aedes and Culex mosquitoes, and reservoir hosts include wallabies and rodents. Burma forest virus cases are also on the rise, primarily in Australia, but also seen in Papua New Guinea. It's spread by similar mosquitoes, but also by biting midges. Horses and possums can be hosts.
And the symptoms are mostly that joint pain.
Yes, the core symptom for both is a sudden onset of disabling, often symmetrical joint pain. Symmetrical meaning it affects both sides of the body, like both wrists or both ankles. And as with chikungunya, this pain can be truly incapacitating for many patients, lasting for more than 6 months in some cases. A non-itchy, diffuse maculopapular rash, flat spots, and small bumps might also develop. Constitutional symptoms like fever aren't always prominent.
Any vaccines for those?
There's an inactivated Ross River virus vaccine that actually completed phase 3 trials with promising results, showing good safety and efficacy. But for various reasons, it hasn't been marketed yet, so not available currently.
Okay, let's talk about Zika. That certainly made huge headlines a few years back. What's its story and what really sets it apart in this group?
Zika virus has a fascinating history. It was actually discovered way back in 1947 in Uganda. But really surprisingly, only 14 clinically identified human cases were reported globally in the entire period before 2007. It was considered quite obscure.
Only 14 cases in 60 years.
Incredible, isn't it? Then, suddenly, things changed. It saw this rapid increase, causing large outbreaks in Micronesia in 2007, then French Polynesia in 2013-2014, and then the big one. Its invasion of the New World, starting in Brazil around 2015, which led to an estimated 440,000 to 1.3 million cases there alone. It spread rapidly to 85 countries by 2017.
Why the sudden explosion, do we know?
That's still debated. Factors like naive populations with no prior immunity, possibly viral evolution, and the presence of highly efficient Aedes mosquito vectors likely all played a role. Interestingly, global Zika activity declined quite rapidly after 2018, again for reasons that aren't entirely clear. But the key insight with Zika, especially compared to chikungunya, is how often it's asymptomatic. Most people infected don't even know they have it. Or if they do get symptoms, they're typically benign, mild, flu-like.
Right, I remember hearing that. Low-grade fever, Maybe a rash, joint pain.
Exactly. Low-grade fever, headache, malaise, often an itchy maculopapular rash, sometimes non-purulent conjunctivitis, red eyes, without pus, muscle aches, joint aches, usually resolves in a week or so.
There's those very serious complications, especially concerning pregnant women. That's what caused the global alarm, wasn't it?
That's absolutely right. While the typical illness is mild, the serious complications are what truly set Zika apart and captured global attention, leading the WHO to declare a public health emergency of international concern. Zika infection during pregnancy was strongly linked to Guillain-Barré syndrome, which is a rare neurological disorder causing muscle weakness and sometimes paralysis. And critically, the most devastating link was to fetal microcephaly following congenital transmission.
Microcephaly, the babies born with abnormally small heads and brain damage.
Precisely. This devastating effect on unborn children was the major driver of the public health emergency. Other neurologic complications like encephalitis were also seen.
And how is Zika spread? Mostly mosquitoes.
Primarily by infected female Aedes mosquitoes, the same ones that spread dengue and chikungunya. But like chikungunya, it can also be transmitted perinatally, mother to baby around birth, through heterosexual and homosexual contact again. That issue of viral persistence in tests for a long time, maybe up to 160 days, and also through blood transfusion.
And treatment or vaccines for Zika.
Currently, no specific antiviral treatments or licensed vaccines are available. So prevention relies heavily on mosquito control and personal protection measures, like using repellents and wearing protective clothing, especially for pregnant women or those planning pregnancy in affected areas.
Okay, let's move on to the next category. Encephalitis, or E. This sounds inherently more severe, involving the brain.
It is, yes. Encephalitis means inflammation of the brain itself, and it's a very serious condition. The major viruses causing arboviral encephalitis are found in families like Flaviviridae, like West Nile, Japanese encephalitis, tick-borne encephalitis, Perbuniaviridae, like lacrosse, Rhabdoviridae, and Togaviridae, like Eastern equine encephalitis. These infections are typically seasonal, usually peaking in the warmer months when their arthropod vectors are most active. And a really crucial point here, similar to what we said earlier, is that for most of these encephalitis viruses, humans are not important amplifiers in nature. We're usually dead-end hosts.
Meaning we get infected, we might get very sick, but we don't usually transmit it back to mosquitoes to keep the cycle going.
Exactly. It's typically an accidental spillover from the natural animal arthropod cycle, but the consequences for us can be severe.
How does the disease typically progress once someone is infected and develops encephalitis?
It usually starts after an infected arthropod bite. The virus first multiplies, often in the lymphoid system, leading to an initial viremia virus in the bloodstream. From there, it manages to cross the blood-brain barrier and enter the central nervous system, the CNS, often setting up infection in multiple spots within the brain. Patients often start with a prodrome and early phase with non-specific flu-like signs, fever, maybe abdominal pain, just feeling unwell, but this can rapidly progress to more alarming symptoms. Severe headache, signs of meningeal irritation like neck stiffness and sensitivity to light, photophobia, vomiting, and then clear signs of brain involvement kick in. Lethargy, confusion, disorientation, potentially slipping into a coma, tremors, palsies affecting cranial nerves like facial drooping, and seizures are common.
That sounds terrifyingly fast. And the outcome?
Outcomes vary depending on the specific virus, the patient's age and health, and how quickly supportive care is started. But yes, these infections can unfortunately be fatal. Or if the person survives, recovery can be very slow and often incomplete. Many survivors are left with persisting long-term neurological deficits, things like difficulty concentrating, chronic fatigue, memory problems, personality changes, recurrent seizures. The impact can be lifelong.
Can you give us some specific examples from this group? Tick-borne encephalitis, TBEV, you mentioned earlier with raw milk.
Right. Tick-borne encephalitis virus, TBEV, it actually has several subtypes with different geographic distributions and slightly different characteristics. The Western or European subtype, the Siberian subtype, the Far Eastern subtype, and one called looping ill, mainly in the UK. As the name suggests, it's primarily transmitted by infected ticks. But the other route is really important to remember. Consumption of raw, unpasteurized milk or dairy products from infected goats, cows, or sheep.
So tick bites or raw milk?
Correct. It's strongly seasonal, mainly occurring between April and October when ticks are active. The disease course can vary. The Western European type often has a bimodal pattern, an initial flu-like phase, then a period of feeling better, followed by the second phase with CNS involvement. The Far Eastern subtype tends to have a more abrupt onset and a more severe course overall.
And how dangerous is it?
The lethality varies significantly by subtype. For the Western European form, it's relatively low, around 1%, but for the Siberian subtype, it's higher, maybe 7–8%, and for the Far Eastern subtype, it can be very high, 20–40%. So it's a serious concern in those regions.
Is there a vaccine?
Yes, fortunately, there are effective formalin inactivated vaccines available. They're recommended for people who are likely to have rural exposure, like hikers or forestry workers, in endemic areas of Europe and Asia. In some places, like Russia, immunoglobulin prophylaxis giving preformed antibodies is also used after a tick bite.
Okay. What about Japanese encephalitis, JEV? You said it's a big concern in Asia?
Japanese encephalitis virus, JEV, is incredibly significant from a public health perspective. It's considered the most important cause of viral encephalitis across Asia. Estimates suggest around 68,000 cases occur each year, leading to somewhere between 13,600 and 20,400 deaths annually. Huge numbers.
Wow. Where is it mainly found?
It's found throughout Asia, from India across to Japan and Southeast Asia. It's often associated with areas that have irrigated rice paddies.
Why rice paddies?
Because those provide ideal breeding grounds for the main mosquito vector, Culex tritaniorhynchus. Pigs and wading birds are important amplifying hosts in the transmission cycle, meaning the virus replicates to high levels in them, making it easier for mosquitoes to pick up and spread. Horses can also be amplifiers.
And the illness itself?
Symptoms range widely. It can be just a nonspecific febrile illness, or it can progress to severe encephalitis. A characteristic feature sometimes seen is a Parkinsonian presentation, tremors, rigidity, movement problems. Seizures are common. Among patients hospitalized with JAV encephalitis, the case fatality rate is high, around 20–30%. And long-term neurologic or psychiatric problems are common among survivors.
Is there a vaccine for JEV?
Yes, thankfully effective vaccines are available. Vaccination is often recommended for travelers spending extended time, especially during the summer transmission season, in rural areas of Asia. Interestingly, vaccination of amplifying hosts, particularly pigs, is also used in some areas as a strategy to help reduce overall transmission.
Let's turn to West Nile virus, WNV. You mentioned it's now the main cause of arboviral encephalitis here in the United States.
That's right. West Nile virus, WNV, really changed the landscape of arboviral disease in the Americas. It was introduced into New York City back in 1999, likely via an infected bird or mosquitoes, and then spread incredibly rapidly across the entire continental U.S., Canada, Mexico, the Caribbean, and into South America.
How does it normally cycle?
Its primary cycle involves wild birds as the main reservoir hosts and Culex species mosquitoes as the primary vectors. Some bird species, like jays and crows, are particularly susceptible. They get very high levels of virus and often die from the infection, making them important indicators of viral activity. Initially, it was mostly Culex pipiens, but now multiple Culex species and even the Asian tiger mosquito, Aedes albopictus, have been implicated in transmission.
And how does it affect humans? Is it always severe encephalitis?
No, definitely not. That's the key point again. Most human infections, maybe 80%, are actually asymptomatic. Of those who do get sick, the most common presentation is West Nile fever, a febrile illness, often with headache, body aches, sometimes a rash, swollen lymph nodes. Pretty nonspecific. Only a small fraction, maybe about 1 in 150 infections overall, develop neuroinvasive disease, meaning meningitis, encephalitis, or acute flaccid paralysis.
Paralysis, like polio.
Yes, it can cause a syndrome that looks very much like polio, with sudden onset muscle weakness. The risk of developing severe neuroinvasive disease and dying from West Nile increases significantly with age, especially over 60, and also in people with underlying conditions like diabetes or hypertension or those who are immunocompromised.
How else can people get West Nile besides mosquito bites?
It's also been transmitted through organ transplantation and blood transfusions. That's why blood and organ donors are now routinely screened for WNV in the U.S. There have also been rare instances of transmission from pregnant women to their fetuses.
Any specific treatment or vaccine?
No specific antiviral treatment exists, so care is supportive. And there's no human vaccine currently licensed. Prevention really focuses on avoiding mosquito bites using repellents, wearing protective clothing, avoiding peak biting times, and community-level mosquito control efforts. Also, safely handling dead birds is important.
Okay, let's talk briefly about the California encephalitis serogroup, particularly lacrosse virus. Where and who does that typically affect?
Lacrosse virus is actually a significant cause of pediatric encephalitis affecting children primarily in the upper Midwestern, Mid-Atlantic, and southeastern United States. It mainly impacts kids under the age of 15.
And how is it spread?
Its main vector is a specific mosquito called Ocleratotus triceriatus, sometimes known as the treehole mosquito.
Treehole mosquito.
Yeah, because it commonly breeds in water that collects in tree holes. But it also readily breeds in man-made containers, especially discarded tires, which are a major source in many areas. And importantly, this mosquito bites during the daytime. Also, lacrosse virus has very efficient transovarial transmission in this mosquito. The virus passes from the female mosquito to her eggs, which can then survive over winter and hatch into infected larvae the next spring. This helps maintain the virus in nature.
And the illness in children.
It typically presents as a sudden onset of CNS disease. Fever, headache, lethargy are common, often with nausea and vomiting. Convulsions occur in about half of the patients, which is quite high, and about a third may experience coma. Sadly, about 10% of patients develop recurrent seizures as a long-term consequence.
How do you prevent lacrosse?
Prevention strategies have focused on environmental modification, reducing or eliminating those breeding sites, like cleaning up tire dumps and encouraging people to empty containers holding water. This has actually been shown to be effective in reducing transmission in some areas.
Finally, in the encephalitis group, Eastern equine encephalitis, EEV. This one has a reputation for being particularly dangerous, right?
It does, unfortunately. Eastern equine encephalitis virus, EEV, is considered one of the most severe mosquito-borne diseases in the U.S. It's primarily found in and around freshwater hardwood swamps, mainly along the Atlantic and Gulf coasts, but activity seems to be increasing and spreading geographically in recent years. Its natural cycle involves birds and a mosquito species, Culiceta melanura, that primarily feeds on birds. Spillover to humans occurs when other mosquito species, bridge vectors that feed on both birds and mammals, get infected and then bite humans or horses. Horses are also very susceptible and often die.
And why is it considered so dangerous for humans?
The overall number of human cases is usually small each year, but the disease is incredibly severe. While only about 2% of infected adults and 6% of infected children develop encephalitis, when they do, it's typically a rapidly progressive and devastating illness. The fatality rate for EEV encephalitis is extremely high, around 30–50%. And even among those who survive, severe and permanent neurological damage, intellectual impairment, personality disorders, seizures, paralysis is very frequent. An indicator of severity can be finding a high number of certain white blood cells, polymorphonuclear leukocytes, in the cerebrospinal fluid early on.
That sounds absolutely horrific. No vaccine for E either.
No licensed human vaccine. Prevention relies entirely on avoiding mosquito bites in endemic areas, especially during late summer and early fall when transmission risk is highest.
Okay, moving on to the third, and you said most common, presentation. Fever and myalgia, or FM. This sounds like it could be easily mistaken for the flu or many other things.
Precisely. This is the most common clinical pattern we see with many zoonotic virus infections. But because it's so nonspecific, just fever and muscle aches, it's often described simply as influenza-like. Though, importantly, it typically doesn't involve the significant cough or coryza, the runny nose, and upper respiratory symptoms that you usually associate with actual influenza. That can be a subtle clue.
What are the typical symptoms then?
It's usually an abrupt onset. Fever, chills, intense myalgia, that muscle pain and malaise, just feeling generally unwell and wiped out. Patients might report joint pain or muscle aches, but usually not the true joint inflammation, the arthritis we talked about with chikungunya. Loss of appetite, nausea, sometimes vomiting, and headache are also common. The illness course can sometimes be biphasic. You feel sick, start to get better, then feel sick again. The overall spectrum is huge, from infections that are completely subclinical, you don't even notice them, to illnesses that are temporarily incapacitating, really knocking you out for a week or two. Less commonly, you might see a non-itchy rash, maybe some nosebleeds, epistaxis, or even aseptic meningitis.
How is it treated? And what's important for prevention, given how common and nonspecific this syndrome is?
Treatment is almost always just supportive. Rest, fluids, managing fever and pain with acetaminophen, for instance. A key point, though, especially with potential dengue or other hemorrhagic fevers that might initially present this way, is that acetylsalicylic acid, aspirin, and other NSAIDs are generally avoided.
Why avoid aspirin?
Because they can potentially increase bleeding risk or, in children, contribute to a rare but serious condition called Ray's syndrome, especially after viral illnesses. So acetaminophen is usually preferred. The general outcome is complete recovery, although sometimes patients experience prolonged asthenia weakness or fatigue that can linger for weeks or months, for example, after lymphocytic choriomeningitis or dengue fever. For prevention, since many different viruses can cause this, it really comes back to vector control. Destroying mosquito breeding sites is often the most cost-effective approach. Newer strategies like releasing genetically modified mosquitoes or mosquitoes infected with Wolbachia bacteria, which can block virus transmission, are being explored and used in some areas. And of course, personal protection is key for you. Using window screens, applying insect repellents containing D-iterpicaridin, wearing long sleeves and pants when outdoors, and trying to avoid peak activity times and habitats for mosquitoes and ticks.
Let's touch on a few specific viruses often presenting as fever myalgia. Lymphocytic choriomeningitis, LCMV. What makes this one unique?
Lymphocytic choriomeningitis virus, LCMV, is an arenavirus. Its main claim to fame, or perhaps notoriety, is its association with the common house mouse, Mus musculus.
House mice. It's found everywhere.
Pretty much worldwide, yeah. Humans usually get infected by inhaling aerosols of dried mouse urine, feces, or nesting materials, or through direct contact with infected mice or their droppings. It can also be transmitted from infected pet rodents, particularly hamsters, which has led to outbreaks, and it's occasionally an occupational hazard in immunology labs that work with mice. What's really crucial from a transmission standpoint is that infected mice often shed the virus in their urine and saliva for their entire lives, acting as silent, chronic carriers.
And the illness, is it just fever and aches?
It often starts gradually with fever, malaise, muscle aches, headache, but LCMV can also be associated with orchitis, inflammation of the testes, transient alopecia, hair loss, sometimes arthritis, cough, or a maculopapular rash. About a quarter of patients experience a biphasic illness. They have the initial febrile phase, seem to get better, and then develop a second phase with renewed fever, severe headache, and signs of meningitis or sometimes mild encephalitis. Hence the name lymphocytic choriomeningitis.
Is there anyone particularly at risk?
Yes, a very important concern with LCMV is infection during pregnancy. If a pregnant woman gets infected, the virus can potentially invade the fetus, leading to serious congenital problems like hydrocephalus, fluid buildup in the brain, microcephaly, and/or chorioretinitis, inflammation of the retina and choroid in the eye, causing potential blindness or vision impairment.
Okay, that's a critical point for pregnant women around potential mouse exposure. What about Arthropod virus?
Arthropod virus is an orthobueniovirus found in Central and South America, particularly the Amazon basin. It's interesting because it's transmitted primarily by a species of tiny biting midge, Culicoides pariensis.
Midges, not mosquitoes.
Right, these tiny biting flies. They often breed in decomposing organic matter like cacao husks and rotting vegetation found in and around towns and villages. Oropos is known for causing really explosive epidemics of febrile illness, sometimes involving thousands or even tens of thousands of patients in a single outbreak. Rash and aseptic meningitis have also been observed during these outbreaks.
The sandfly fever group sounds like it would also be geographically specific and maybe vector specific.
It is, yes. This group of viruses, which are phlebiviruses within the Phenoviridae family, are transmitted by, unsurprisingly, phlebotomine sandflies.
Sandflies, are they like mosquitoes?
They're much smaller, and they have a characteristic hopping flight. A practical challenge is that they're tiny enough to pass through standard mosquito screens. These viruses are found primarily in the circum-Mediterranean region, extending through the Balkans, the Middle East, into Western Asia, and parts of China. Epidemics often occur, sometimes linked to environmental disruptions like natural disasters or wars, which might increase sandfly populations or human exposure. For travelers to these regions, sandfly fever is a relatively common cause of sudden onset fever, headache, and muscle aches. Local populations, however, are often immune due to childhood infections. One specific virus in this group, Toscana virus, found mainly in Italy and surrounding Mediterranean countries, is frequently associated with causing aseptic meningitis, sometimes even meningoencephalitis.
Okay. And finally, in this fever myalgia category, the big one, dengue viruses 1 through 4. You mentioned it's probably the most prevalent arboviral disease globally.
Dengue is absolutely huge on a global scale. It's caused by 4 distinct but closely related virus serotypes: DNV1, DNV2, DNV3, and DNV4. Infection with one serotype provides lifelong immunity to that specific type, but only temporary partial protection against the others. It's estimated there are around 400 million dengue infections occurring worldwide each year. Of those, maybe 100 million actually cause clinical illness, ranging from mild fever to severe disease. It's endemic in more than 100 countries, mostly in tropical and subtropical regions.
And the vectors?
The primary vectors are 2 Aedes mosquito species, the yellow fever mosquito, Aedes aegypti, and the Asian tiger mosquito, Aedes albopictus. Both are highly adapted to urban environments, breed readily in artificial containers around homes, and preferentially bite humans during the daytime. This makes them incredibly efficient at spreading dengue in densely populated areas.
What does classic dengue fever feel like?
After an incubation period of about 4 to 7 days, the illness typically has 3 phases: febrile, critical, and recovery. The febrile phase is characterized by a sudden onset of high fever, often accompanied by a severe frontal headache, pain behind the eyes, retroorbital pain, intense back pain, and severe muscle and joint aches. This is why it earned the nickname breakbone fever. It can be incredibly painful. A transient macular rash might appear early on, followed later by a more characteristic maculopapular or sometimes scarlet-like rash. Minor bleeding manifestations like nosebleeds or petechiae, those tiny red spots under the skin, are also quite common.
But dengue can get much worse. Yeah. We'll come back to severe dengue later.
Exactly. While this classic dengue fever is debilitating, most people recover fully, but a proportion of patients can progress to severe dengue, which we'll discuss under the VHF category.
Okay, shifting now to the fourth category, pulmonary disease, or P. The main one I'm seeing highlighted here is hantavirus pulmonary syndrome, HPS.
That's right. Hantavirus pulmonary syndrome, HPS, is the primary example in this category. It's a relatively newer recognized disease, first described in the Four Corners region of the U.S. back in 1993, although retrospective analysis identified earlier cases. HPS is caused by several different orthohantaviruses found in the Americas, what are sometimes called New World hantaviruses. The primary cause in the U.S. is Sin nombre virus, which chronically infects the North American deer mouse, Peromyscus maniculatus. Other related viruses carried by different rodent species cause HPS elsewhere in North and South America.
And you mentioned Andes virus earlier as being unique.
Yes, Andes virus, which causes HPS in parts of South America, is highly unusual among hantaviruses because it's the only one clearly documented to cause human-to-human transmission, primarily through close contact. For Sin nombre and other North American hantaviruses, person-to-person spread doesn't seem to occur.
So how do people typically get HPS from Sin nombre virus?
Infection usually occurs through inhalation of aerosols contaminated with virus shed in rodent urine, droppings, or saliva. This often happens when people are cleaning out sheds, cabins, or homes where deer mice have been present, or sometimes through occupational exposures involving rodents. Rural residents living in dwellings that are easily permeable to rodents are generally at higher risk.
What are the symptoms?
Wow.
Does it start like a cold?
It typically begins with a prodrome phase lasting several days, characterized by fever, malaise, muscle aches, especially in the back and hips, and often gastrointestinal disturbances like nausea, vomiting, or abdominal pain. Respiratory symptoms are usually absent initially. Then the illness rapidly progresses to the pulmonary phase. Patients develop shortness of breath and cough and quickly deteriorate with severe hypoxemia, dangerously low oxygen levels in the blood, and respiratory failure as fluid leaks into their lungs, non-cardiogenic pulmonary edema. What's often surprising is that early on, even when the patient is becoming very short of breath, the physical examination of the chest might reveal very few abnormal findings like crackles.
That sounds incredibly dangerous and fast-moving. What are the key diagnostic clues doctors look for, and how is it managed?
Some key laboratory clues that strongly suggest HPS in the right clinical setting include thrombocytopenia, a very low platelet count, the presence of circulating atypical lymphocytes, a specific type of white blood cell, a left shift in the white blood cell count indicating immature cells, hemoconcentration, thickened blood due to fluid leakage, and hypoalbuminemia, low protein levels in the blood. Management is all about intensive supportive care, and time is critical. The main goal in the first few hours is to prevent severe hypoxemia using supplemental oxygen, and often early intubation and mechanical ventilation are required. However, aggressive fluid administration needs to be done with extreme caution. Patients often have myocardial depression, weakened heart function, and that increased pulmonary vascular permeability. Giving too much fluid can actually worsen the lung edema and shock. Vasopressors, medications to support blood pressure, are often needed.
And the outcome?
Despite the best modern critical care, HPS remains a very severe illness with a high fatality rate, historically around 30–40%. Early recognition and expert intensive care are crucial for survival.
Okay, the last and perhaps most dramatic category, viral hemorrhagic fever, or VHF. This term itself sounds incredibly serious.
It is. VHFs represent a constellation of illnesses caused by several distinct families of viruses, including Arenoviridae, Bunyivirales, specifically Nairoviridae and Phenuviridae families, filoviridae, which we'll touch on separately, and flaviviridae. What ties them together symptomatically is this syndrome involving vascular instability and decreased vascular integrity. Basically, the blood vessels become leaky. This leads to increased permeability, problems with platelet function and clotting, and often localized bleeding, like petechiae or easy bruising. A positive tourniquet test where petechiae appear after inflating a blood pressure cuff can be an early sign. As the illness progresses, blood pressure can drop, leading to shock in severe cases.
What are the typical symptoms leading up to that?
The acute phase usually involves ongoing virus replication and viremia. Symptoms typically begin abruptly, except for arenavirus infections like Lassa fever, which can be more gradual with fever, muscle aches, and increasing prostration, just overwhelming weakness. Patients often develop abdominal or chest pain, severe headache, nausea, and vomiting. Signs like flushing of the skin, swelling around the eyes, periorbital edema, and protein in the urine, proteinuria, are common. Liver enzyme levels, particularly AST, are often elevated. Hemoconcentration, that thickening of the blood, can occur due to plasma leakage. The development of shock, multifocal bleeding, bleeding from multiple sites like gums, nose, injection sites, or internally, and CNS involvement, confusions, seizures, coma, are all considered very poor prognostic signs.
How do doctors diagnose these, especially differentiating them from other infections? And how are they treated? It sounds incredibly challenging.
Diagnosis relies heavily on clinical suspicion, especially in a patient with relevant travel history to an endemic area. It's absolutely critical to quickly differentiate potential VHFs from other treatable, potentially lethal infections that can present similarly, like bacterial sepsis, malaria, typhoid fever, or leptospirosis. Treatment requires prompt hospitalization, ideally in a center experienced with managing these illnesses. Very careful, judicious fluid therapy is essential. You need to replace lost fluids due to leakage and dehydration, but overly aggressive fluid loading can be dangerous and worsen pulmonary edema or shock. It's a difficult balance. Doctors often need to use cardiotonic drugs to support heart function and vasopressors to maintain blood pressure. Treating secondary bacterial infections is important. In some cases, replacement of clotting factors or platelets might be considered, although the benefit is often debated. And a key public health insight, absolutely critical for healthcare workers and facilities, is the need for strict barrier nursing precautions for most VHFs.
Why is that so critical? Person-to-person spread.
Yes, many VHFs, like Lassa, Ebola, Marburg, Crimean Congo, and the South American haemorrhagic fevers, can be transmitted from person to person through direct contact with infected blood or body fluids. This poses a significant risk in healthcare settings if proper infection control isn't rigorously maintained. However, it's important to note, for you listening, that for some viruses sometimes classified within the VHF spectrum, like dengue, orthohantaviruses causing HFRS, Rift Valley fever, and yellow fever, significant person-to-person transmission in natural settings or healthcare environments outside of needle stick injuries has not been documented. This influences the specific level of precautions needed.
Okay, that's a very important distinction for infection control. Can you give us some examples of specific VHFs? Maybe start with Argentinian and Bolivian hemorrhagic fevers.
Sure. These are caused by Junian virus, Argentinian HF, and Machupo virus, Bolivian HF, respectively. Both are arenaviruses transmitted by rodents. They cause severe diseases with fatality rates that can reach 15–30% if untreated. Their clinical presentations are quite similar, typically involving marked thrombocytopenia, low platelets, frequent bleeding manifestations, and often significant CNS dysfunction like tremors, delirium, or seizures. Person-to-person transmission is considered rare, but has occasionally occurred, usually through very close contact. Nosocomial transmission in hospitals has also happened, though infrequently. Post-recovery counseling to avoid intimate contact for a period is sometimes suggested due to potential virus shedding.
Is there any treatment?
Yes, a major success story here is that both Argentinian and Bolivian HF can be effectively treated with administration of convalescent phase plasma collected from patients who have recovered from the disease and contain protective antibodies. This significantly reduces mortality if given early. Intravenous ribavirin, an antiviral drug, is also thought to be effective. Furthermore, a safe and highly effective live attenuated vaccine called Candid #1 exists for Argentinian hemorrhagic fever. Its widespread use in Argentina has dramatically decreased the incidence of the disease, and importantly, this vaccine appears to provide cross-protection against Bolivian hemorrhagic fever in experimental animal models, which is very promising.
That's great news about the vaccine and plasma treatment. What about Lassa fever, which you mentioned is endemic in West Africa?
Lassa fever, caused by Lassa virus, another arenavirus, is a major public health problem in several West African countries, like Nigeria, Sierra Leone, Liberia, and Guinea. It's a prominent cause of febrile illness in these regions, with estimates of tens of thousands, perhaps hundreds of thousands, of infections occurring annually, though many are likely mild or asymptomatic. Transmission is primarily from the rodent reservoir, the multimully rat, Mastomes natalensis, through contaminated food or inhalation. However, Lassa can also be transmitted by close person-to-person contact, particularly through exposure to infected body fluids like blood, urine, or semen, where the virus can persist. Nosocomial spread has been a problem historically, but is uncommon now with proper sterile techniques and barrier nursing.
And the symptoms, is it always hemorrhagic?
The onset is typically gradual, unlike many other VHFs. And interestingly, significant hemorrhage or bleeding is actually seen in only a minority of hospitalized patients, maybe around 15–30%. So while classified as a VHF, bleeding isn't its most defining feature clinically. Lassa fever can be particularly severe in pregnant women, especially during the third trimester, with high rates of maternal mortality and fetal loss, often exceeding 90%. Another really important and often devastating complication of Lassa fever is deafness. About 20% of patients experience hearing loss, which is often permanent and can be bilateral, affecting both ears.
Deafness. Wow, that's a surprising and terrible outcome. Is there treatment for Lassa?
The antiviral drug IV ribavirin appears to be partially effective, especially if started very early in the course of illness, within the first 6 days. However, it's not a magic bullet, and it does have potential side effects like reversible anemia or bone marrow suppression, which need to be monitored. Supportive care remains crucial.
Okay. Hemorrhagic fever with renal syndrome, HFRS. You mentioned this is the most significant VHF today in terms of numbers.
Yes, in terms of sheer number of cases globally, hemorrhagic fever with renal syndrome, HFRS, is probably the leader among the VHFs. It's estimated that over 100,000 cases of severe HFRS occur in Asia annually, plus thousands of milder infections, often called nephropathia epidemica, seen in Europe. It's widely distributed across Eurasia. HFRS is caused by several different Old World orthohantaviruses. Pulmonary is common in Europe, causing the milder form. Dubrava virus causes a more severe form in the Balkans. Hantoan virus is a major cause of severe HFRS in Eastern Asia, particularly Korea and China. And Sol virus, associated with domestic brown rats, Rattus norvegicus, has a worldwide distribution, including cases in urban areas.
And how is HFRS transmitted? Is it person to person?
Transmission is primarily through inhalation of aerosols from infected rodent urine, saliva, or feces. Direct contact might also play a role.
Yeah.
But a really key public health insight and a relief for healthcare workers is that unlike Lassa or Ebola, patients with HFRS are generally not considered infectious to others. Person-to-person transmission doesn't seem to occur.
That's a huge difference. What does the illness look like? The name mentions kidneys.
It does. The clinical course of classic severe HFRS typically evolves through 4 distinct phases: febrile, hypotensive, oliguric, low urine output, and finally polyuric, large volume of urine production, during recovery. It's characterized by abrupt onset of fever, severe muscle aches, especially back pain, headache, flushing of the face and chest, petechiae, often conjunctival injection, red eyes, and sometimes blurred vision. A key feature is evidence of vascular leakage, particularly causing retroperitoneal edema, swelling behind the abdominal cavity, which contributes to the back pain and can lead to shock in the hypertensive phase. Proteinuria, protein in the urine, is almost always present, and kidney involvement, ranging from mild dysfunction to acute renal failure requiring dialysis, is the hallmark of the disease, especially in the oliguric phase. Hemorrhagic manifestations can occur, but are usually less prominent than in some other VHFs.
How is HFRS managed?
Management focuses on careful fluid balance, treating shock, often relying on vasopressors rather than just fluids, managing electrolyte abnormalities, and providing renal replacement therapy, dialysis, if acute kidney failure develops. Like with Lassa fever, early administration of 5E ribavirin within the first 4 days of fever has been shown in studies, particularly in China, to reduce mortality and morbidity from HFRS caused by Hantoan virus.
Okay, Crimean Congo hemorrhagic fever, CCHFE. Where is that found?
Crimean Congo hemorrhagic fever virus, CCHFV, is a narrovirus in the Bunyavirales order, and it has one of the widest geographic distributions of any medically important arbovirus. It's found across Eastern Europe, including the Balkans, the Mediterranean, northwestern China, Central Asia, Southern Asia, the Middle East, and large parts of Africa, basically, wherever its principal tick vectors, mainly Hyaloma species ticks, occur.
Kicks again. How do humans get it?
Primarily through the bite of an infected tick, or by crushing an infected tick. However, transmission also occurs through direct contact with the blood or tissues of infected livestock, like cattle, sheep, goats, during slaughter or shortly after. The animals themselves usually don't show obvious illness, and critically, CCHFV is notorious for causing nosocomial outbreaks spreading within hospitals or healthcare settings through exposure to infected patient blood or body fluids. Strict infection control is absolutely essential when caring for CCHF patients.
What are the key features of the illness?
CCHF is a severe VHF. Patients often develop extensive liver damage, which can lead to jaundice. Disseminated intravascular coagulation, DIC, a widespread clotting problem, is common. Liver enzymes, especially AST, are typically very high. Compared to survivors, non-survivors often have higher white blood cell counts, leukocytosis, and more profoundly low platelet counts, thrombocytopenia. Hemorrhage is frequent and can be severe.
Treatment option.
Treatment is mainly supportive care. The efficacy of ribavirin for CCHF is controversial. Some studies suggest a possible benefit, especially if started early, while others haven't shown clear effectiveness. There are currently no widely recommended or licensed human or veterinary vaccines available for CCHF.
Okay, Rift Valley fever, RVFV. Another one with a wide range.
Rift Valley fever virus, RVFV, is a virus, also Bunyavirales. Historically, it was mainly confined to sub-Saharan Africa, where it causes periodic, large epizootics outbreaks in animals, particularly in sheep, goats, and cattle, often associated with periods of heavy rainfall.
Why heavy rainfall?
Because it favors the hatching of eggs from its primary maintenance vectors, certain floodwater Aedes mosquito species. These mosquitoes can transmit the virus transvarially to their eggs, which can then lie dormant in dry soil for years, hatching when flooding occurs. The virus has spread beyond Africa, notably causing a large outbreak in Saudi Arabia and Yemen starting in 2000.
How do humans get infected?
Increased transmission during these heavy rain periods leads to large outbreaks in livestock, often causing high rates of abortion in pregnant animals and death in young animals. Humans typically get infected through direct contact with the blood, body fluids, or tissues of infected animals, especially during birthing, slaughtering, or veterinary procedures. Inhalation of infectious aerosols generated during these activities is also thought to be an important route. Mosquito bites are another way humans get infected, particularly by secondary mosquito vectors during epizootics. But critically, and this is another important distinction for you, significant person-to-person or nosocomial transmission of RVFV has not been documented.
No person-to-person. Good to know. What does the human illness look like?
Most human infections are actually relatively mild, presenting as that non-specific fever myalgia syndrome we discussed, lasting a few days. However, a small proportion of patients, maybe 1–2%, develop more severe disease. This can manifest as VHF, often with prominent liver involvement, hepatitis, jaundice, hemorrhage, which has a high fatality rate, around 50%. Or it can present as encephalitis, sometimes delayed, appearing weeks after the initial fever. Another significant complication, seen in perhaps up to 10% of even milder infections, is retinal vasculitis, inflammation of the blood vessels in the eye. This can lead to permanent vision impairment or blindness in some cases, and its occurrence is sometimes followed by the onset of delayed encephalitis.
How is it prevented?
Livestock vaccination is a key strategy for controlling RVF and preventing epizootics. There is a human vaccine, a formalin inactivated one, but it's available only in limited quantities and typically used just for laboratory workers or veterinarians at high risk of exposure. Mosquito control and avoiding contact with infected animal tissues are also important.
Okay, let's circle back to dengue. You mentioned some people develop severe dengue. How does that happen, and what does it look like? This seems like a major global issue.
It absolutely is. While most of the millions of annual dengue infections are subclinical or result in classic dengue fever, a certain proportion of patients, particularly children and young adults, enter a critical phase, usually around the time the fever starts to subside, defervescence, between days 3 and 7 of illness. This is when they can develop severe dengue. Severe dengue is defined by one or more of 3 major features. First, severe plasma leakage from blood vessels, leading to shock, dengue shock syndrome, or fluid accumulation causing respiratory distress. Second, severe bleeding, or third, severe organ dysfunction involving the liver, CNS, heart, or kidneys.
Why do some people get severe dengue and others don't? Is it random?
It's not random, although the exact factors aren't fully understood. A key determinant of risk, a really critical insight into dengue pathogenesis, is thought to be immune-mediated enhancement of disease.
Immune enhancement, how does that work?
It's often seen during a secondary infection with a different dengue virus serotype than the first infection. For example, if you had DNV1 years ago and then get infected with DME2, the antibodies you have from the first infection might, paradoxically, help the second virus infect certain immune cells more efficiently. This can lead to a higher viral load and a more exaggerated immune response, triggering the plasma leakage and severe disease. Prior immunity makes the second infection worse, not better.
Wow, that's counterintuitive. Your immune system working against you.
Exactly. It's a major challenge for vaccine development. Among the millions of infections, it's estimated there are about 500,000 cases of severe dengue annually, worldwide, with a case fatality rate of around 2.5% overall, though it can be much higher if not managed properly.
What are the warning signs for severe dengue?
Warning signs that might predict progression to the critical phase include persistent vomiting, severe abdominal pain, fluid accumulation, like pleural effusions seen on ultrasound, mucosal bleeding, lethargy or restlessness, and liver enlargement. Laboratory signs like a rising hematocrit indicating hemoconcentration due to plasma leak, concurrent with a rapidly falling platelet count are classic indicators. The vascular leak syndrome is notorious. Plasma leaks out of the blood vessels, leading to depletion of intravascular volume, low blood pressure, effusions, fluid in body cavities like the chest, and potentially circulatory collapse and shock. Organ involvement can include severe hepatitis, encephalitis, myocarditis, heart inflammation, kidney failure, or ocular problems.
How is severe dengue treated? And what about prevention, especially given that immune enhancement issue?
Treatment is entirely supportive, but it requires meticulous management, especially careful fluid resuscitation guided by clinical signs and hematocrit levels. Close monitoring in a hospital setting is essential during the critical phase. With experienced care, the fatality rate can be reduced to less than 1% in specialized centers. Prevention primarily relies on controlling the Aedes mosquito vectors, eliminating breeding sites, using insecticides, etc. A tetravalent live attenuated dengue vaccine called Dengvaxia was licensed a few years ago.
A vaccine? That sounds like a breakthrough.
It was hoped to be. However, subsequent analysis revealed a significant issue. The vaccine actually increased the risk of hospitalized severe dengue in vaccine recipients who were seronegative, meaning they had never been infected with dengue before vaccination. It seemed to mimic that immune enhancement phenomenon.
Oh no, so the vaccine could make things worse for some people?
For those without prior exposure, yes. As a result, the WHO now recommends pre-vaccination serologic screening. The vaccine should ideally only be given to individuals who have laboratory confirmation of a past dengue infection, seropositive individuals, in whom it appears to be safe and protective. This really highlights the complexity of dengue immunity and vaccine development.
Absolutely. Finally, let's talk about yellow fever, YFV, a disease with a really long and impactful history, right? It shaped cities and even global events.
Yellow fever virus, YFV, a flavirus, definitely has a storied history. It caused devastating epidemics in Africa, the Americas, and even Europe for centuries before its transmission by Aedes aegypti mosquitoes was finally proven by Walter Reed and colleagues around 1900. This discovery was a landmark in public health and led to effective vector control strategies.
Is urban yellow fever still a problem?
Urban yellow fever, transmitted person to mosquito to person by Aedes aegypti, is now mostly controlled in the Americas due to mosquito control efforts, although the potential for reemergence exists wherever the mosquito is present. However, urban transmission still occurs in some African cities. But yellow fever virus also persists in a sylvatic or jungle cycle in parts of Africa and Central and South America. This involves transmission between non-human primates and forest-dwelling mosquitoes. Humans can get infected when they enter these jungle areas.
So it's still out there in the wild?
Yes. Hundreds of jungle cases occur annually in South America, often affecting forestry or agricultural workers. And Africa continues to experience large outbreaks, sometimes involving thousands of cases and deaths, like major outbreaks in Angola and the DRC in 2016, and Nigeria more recently. It remains a significant threat.
What does the illness look like? Why yellow fever?
It's a classic VHF presentation, but with particularly prominent liver damage, hepatic necrosis. This liver damage leads to jaundice, yellowing of the skin and eyes, which gives the disease its name. It also contributes to the severe bleeding tendency often seen. Besides liver failure and hemorrhage, yellow fever can also cause acute kidney injury, myocardial injury, heart damage, and sometimes encephalitis. The illness often has a biphasic course, an initial phase of fever and aches, then perhaps a brief remission, followed by a toxic phase in about 15% of patients, characterized by the return of fever, jaundice, bleeding, like vomiting black material digested blood, and organ failure. The fatality rate among patients who enter the toxic phase is very high, often 50% or more.
How is it prevented? There's a famous vaccine, isn't there?
Yes. Urban yellow fever is prevented primarily by controlling Aedes aegypti mosquitoes. But for the ongoing sylvatic cycles, vaccination is the key preventive measure, especially for anyone living in or traveling to endemic areas in Africa and South America. We have a highly effective and generally very safe live attenuated vaccine known as the 17D vaccine. A single dose provides long-lasting, likely lifelong immunity for most people. Recent studies suggest protection lasts at least 25-35 years, maybe longer. It's been a major public health success story.
Are there any issues with the vaccine?
It's generally very safe. However, it is contraindicated, should not be given, to infants under 6 to 9 months, depending on recommendations, due to a risk of vaccine-associated encephalitis. Caution is also advised for the elderly, over 60, and immunocompromised individuals due to rare but potentially serious adverse reactions, including neurologic disease or severe systemic illness resembling yellow fever itself, viscerotropic disease. But for most travelers, the benefits far outweigh the risks.
Okay, finally, let's just briefly touch on another class of viruses that have certainly captured global attention and, frankly, strike a different kind of public health alarm. The filoviruses. Their mode of transmission seems notably different from many we've just explored.
Indeed. Filovirus is the family that includes Ebola virus and Marburg virus are known for causing extremely severe and frequently fatal human infections. Their introduction into human populations is, thankfully, thought to be an extremely rare event. It most likely occurs through direct or indirect contact with the natural reservoir hosts, which are believed to be fruit bats for both Ebola and Marburg, or possibly through contact with other infected mammals that might have been infected by bats, like non-human primates.
And once it's in humans, how does it spread? We hear a lot about how contagious Ebola is.
That's a really critical point to clarify. Filoviruses are highly infectious, meaning exposure to even a small amount of virus can cause infection. However, they are not exceptionally contagious in the way that, say, measles or influenza are, which spread easily through the air. There is no evidence to support aerosol or respiratory droplet transmission of filoviruses during natural human outbreaks. Human-to-human transmission occurs primarily through direct contact, like broken skin or mucous membranes, with the blood, body fluids like urine, feces, vomit, saliva, semen, or tissues of an infected person, or through contact with contaminated objects like needles. This makes rigorous infection prevention and control, especially barrier nursing, absolutely paramount in managing outbreaks.
And the symptoms. They sound devastating from the news reports.
Infections typically start with a nonspecific, abrupt onset of flu-like symptoms. Fever, chills, severe headache, muscle aches, fatigue. But this rapidly progresses over several days to include severe gastrointestinal manifestations, nausea, vomiting, diarrhea, abdominal pain. Many patients then develop coagulopathy, problems with blood clotting, leading to bleeding manifestations, though massive hemorrhage isn't always the most prominent feature. The disease often progresses to multiple organ dysfunction, shock, and, unfortunately in many cases, death. Fatality rates for Ebola and Marburg have historically been very high, ranging from 25% to 90% depending on the specific virus species and outbreak context.
You mentioned virus persistence earlier with Zika and LCMV. Does it happen with filoviruses too?
Yes, that's been a significant finding, especially after the large West African Ebola outbreak. Survivors can remain persistently infected, with virus lingering for months or even longer in certain immune-privileged sites, places where the immune system has limited access. This includes the male reproductive tract, leading to potential sexual transmission long after recovery, the central nervous system, and intraocular tissues within the eye, which can cause vision problems. This requires long-term monitoring of survivors.
What advancements have been made in treating and preventing these, especially since those major Ebola outbreaks? It seems like things have changed.
They really have. Historically, our main tools were fundamental public health and epidemiologic approaches. Rapid case identification, isolation, meticulous contact tracing to find and monitor anyone exposed, strict infection prevention and control measures in healthcare settings, and culturally sensitive, safe burial practices to prevent transmission from deceased patients. Supportive medical care was often quite limited, especially in resource-poor settings. However, the devastating 2013-2016 Western Africa Ebola outbreak served as a massive catalyst for research and development. We've seen truly groundbreaking breakthroughs since then.
Like vaccines and treatments.
Exactly. We now have the widespread deployment of an incredibly effective Ebola virus-specific vaccine, the RVSV-Zebovi vaccine, which uses a ring vaccination strategy during outbreaks and has been a game changer for control. There are also now effective therapeutics available, specifically monoclonal antibodies, engineered antibodies that directly target the Ebola virus. Several of these, like Inmeza and Ibonga, were proven effective in randomized controlled trials conducted during recent outbreaks and are now used for treatment. And alongside these specific tools, there's been a major push to deliver much more advanced supportive care, even in outbreak settings, focusing on things like fluid and electrolyte management, which has also significantly improved survival rates. But it's crucial to remember these are WHO risk group 4 pathogens, the highest risk category, requiring maximal containment facilities, biosafety level 4, BSL-4, for any laboratory work involving replicating viruses.
What an incredible and sometimes sobering deep dive into this vast, complex, and constantly evolving world of zoonotic viruses. We've really seen how understanding their unique transmission cycles, the vectors, the reservoirs, the routes to humans, and the wide range of syndromes they cause, from rashes to hemorrhagic fevers, plus the targeted prevention strategies. It's all absolutely key to living informed in a world full of these microscopic agents.
It truly is. It underscores the intricate connections within our ecosystems, the animal world, the environment, and human health. And it shows how human activities, land use changes, travel, climate change, how all these things can inadvertently bring us into closer contact with these viral cycles, sometimes in really unexpected ways.
Exactly. And that brings us to our final thought for you to ponder. As environmental changes continue to reshape our world-shifting temperatures, rainfall patterns, habitats, how might the distribution and the seasonal activity of these arthropod-borne and rodent-borne viruses shift in the coming decades? And maybe more importantly, what does this mean for global preparedness, for our health systems, and perhaps even for our individual roles in public health? We invite you to consider what aspects of this deep dive resonated most with you today, and perhaps what questions it sparked for your own further exploration into this fascinating and critical topic.